Hi, my name is Asunto. I'm actually a second year resident of the Adventist Health Tulare. Today I'm going to go over with my presentation on population health, integration of the community medicine curriculum via utilization of the mobile care clinic. But before I proceed, I'd like to acknowledge the people involved here, my colleague Dr. Cherwoo, and our faculty members, Dr. Laimer, Dr. Sammons, and our beloved Dr. Khan. He's our PD. Um, the picture down here on the left is actually the mobile care clinic, which we acquired approximately 3 years ago. It is currently being staffed with one intake person, two medical assistants, and at least one resident with one attending or preceptor the resident if needed. So going over with the introduction, the mobile care clinic provides convenient access to medical care in remote areas, underserved communities in Central Valley of California, regardless of insurance status, aligning with the Adventist Health mission, which is living God's love by inspiring health, wholeness, and hope. So these underserved communities are the ones listed here in Figure 1 with the HEPSA score. By the way, HEPSA score determines if there's a higher need for clinicians in the area. The higher the number, the higher need of a doctor. Like 5 points, for example, you could be driving 30 to 40 minutes without even finding a clinic or any clinicians in the area. This is a quality improvement project to support a structured 3-year residency community medicine curriculum as part of the longitudinal population health education. The mobile care clinic improves healthcare access and enhances the residents' understanding of the social determinants of health when evaluating health problems of population by applying pop health science to practice, using quality metrics, data and technology, enhancing patient care and resident engagement. This van, like I mentioned, is operational and this high HEPSA scores, the one listed here in Figure 1. Up here is just comparison of the California state in terms of these attributes. Yeah. Going over objectives, to support the structured 3-year residency community medicine curriculum as part of the longitudinal population health education, to improve healthcare access to remote locations, to learn more about social determinants of health and application of population health education, to develop a standardized process by designing algorithms for the management of different diseases, utilizing the PDC cycle and providing quality care. So down here in Figure 4 are the top 5 social determinants of health recognized by CMS. We have the homelessness, utilities. Some of these people haven't showered in a long time. So there are actually agencies that come and, they're bringing like shower truck, for example. Food insecurity. Some agencies are also bringing food, giving food to everybody. And Adventist Health also participated in this. Sometimes we bring snacks and just we have it in the mobile van so we can hand it over to them as well. These patients have problems with transportation. They have problems coming to the clinic. Safety and security is another part of the social determinants of health. So population health is actually is defined in so many ways, and one big part of it is the community medicine that we're supporting on for the curriculum. On top of that, we have the medical cost management, value-based care, coordination of care so that we can follow the patient and not lose them to follow up. Quality and patient safety, that's what we do like IPA sign out, or we can do like M&M. Data and analytics, information technology, this relates to the AMR and the medical records, special projects like reducing teen pregnancies in the area or reducing sepsis rates, patient-centered medical home, leadership development, healthcare finance. As you can see, there's a lot of involvement in terms of financing with population health. Insurances are involved in this in healthcare. In terms of methodology, actually, when we first started with the mobile van, when we acquired it, there was no standardized process. So we came to the idea that maybe we should be um, building a simple algorithm wherein there's like a simple input to get the desired output by just following a set of rules. However, due to the complexities of the human body and given the myriad diseases that we encounter, we came to realize that maybe we should add some parameters like numeric parameters, symptomatic parameters, and we were able to come up with hypertension. And this cycle, we did a lot of revisions on this based on the Plan, Do, Study, Act cycle. Um, I'm only showing one here, which is the hypertension, but we actually did other six flowcharts that we did for hypotension, temperature, diabetes, anemia, hypoxia, hyperlipidemia, um, at the same time utilizing the PDSA cycle. For example, here in hypertension, we check the BP and we use the numeric parameters. If it's greater than 200 or equal to 200 over 120, send them to the ED. If it's less than that, then they have the symptoms here like severe headaches, acute visual changes, all those things here. We send them to the ED, but sometimes they don't want to go to the ED, so we provide warm handoffs at PCP, set up an appointment for the patients, and have them established with Adventist Health Clinic if they don't have PCP. So down here is the result of the services that we provided, vaccinations, all those things. But it looks like in 2021, we actually didn't do any influenza vaccination in sports physical. Overall, we did like a lot of COVID vaccinations shown here. Going over the conclusions, the community medicine curriculum was integrated into the three-year pop health education. So we're able to integrate this curriculum. The mobile care clinic service increases healthcare access for underserved communities. Um, we actually see more people coming to the area as we become more frequent to the area. The residents develop an enhanced understanding of population health science by evaluating social determinants of health and applying theory into practice through managing patients in low resource area. So we learn directly from patients, which is a good thing. And there are things you don't see in the clinic that you see in the community. You get to learn to understand the value of the money, whether they want to spend it for food, a $10 bill, $5 bill for food, or to spend it in the clinic, or to buy it for clothes versus spending it for the lab test. So we learn so much from the community. Appropriate treatment plans for patients dealing with multiple healthcare issues are generated utilizing standardized complex algorithms, which are continuously revised within the PDC cycle. So we still revise them. Sometimes we found some, especially that um, some changes in the guidelines. So we also modify the algorithms. The mobile care clinic aims to eventually in the future, we aim to include like medication prescriptions. We're trying to get the license for the ban, medication assisted treatment and street medicine. That ends my presentation and thank you so much for this opportunity.